Good morning. We are having a ward round discussion today, which is very important and it's a very commonly asked ward round scenario. A case of pancreatic fistula following Whipple's procedure. So, Milind is showing you the case scenario. You read the case scenario and wait for the next part of discussion. Okay. Anish Pandey will be presenting today, and he is a third year DNB resident at RKM Share Position, Government Institute of Medical Sciences. And with us today will be Professor Prashanta Kumar Bhattacharya, who is Professor of Surgery at Bakura Shomini Medical College. So, please show the scenario. Anish, you can read the scenario.
Yes.
Yeah.
Good morning to all of you, sir. A 55-year-old gentleman on the 8th post-operative day after Whipple's presents with abdominal pain, distension, and bilious vomiting, which led to the reinsertion of nasogastric tube on the 7th post-operative day. Drainage of slightly turbid fluid 100 ml per day through the operatively placed abdominal drain since 3rd post-operative day. Looked ill, febrile, temperature is more than 38 degrees Celsius, pulse is 100 per minute, respiratory rate is 24 per minute. Persistently increasing C-reactive protein equivalent to 45 milligram per deciliter since post-operative day 4. The total leukocyte count is 12,400. USG of the abdomen, there is a significant collection in the subhepatic and the left subphrenic space. So this is the
okay. So there is a scenario, Dr. Bhattacharya, please.
Okay, Anish.
Good morning, sir.
Good morning. So, based on this scenario, what do you think is the probable complication from which this particular patient of pancreatic duodenectomy is suffering from?
Sir, as the patient underwent Whipple's procedure, and there is a collection starting from the 3rd post-operative day, and there is a USG of the abdomen showing the significant collection in the subhepatic and left subphrenic space. So, in my opinion, sir, there will be a chance of pancreatic fistula formation after the surgery.
You just stop at that point. I'd like to specify a little more because some findings are also given. Just saying pancreatic fistula would not suffice.
So there is a drainage of slightly turbid fluid. Hello.
Yeah. Dr. Bhattacharya, you happy or you want some more specification for this diagnosis? Yeah. Oh, Dr. Bhattacharya is probably out.
Mute.
Oh. Dr. Bhattacharya, you are muted.
Oh, okay. Sorry.
Yeah. So I asked him.
Anish.
Yeah.
Anish.
Yes, sir.
You have highlighted certain points here in this case scenario. What is the idea behind it?
Sir, yes, sir. Hello, sir.
Like for example, you said the patient is ill, febrile, patient is having tachycardia, tachypnea. What does it indicate?
Sir, the highlighted points indicate, sir, as the patient is having raised temperature, tachycardia, and tachypnea. So there is a chance of underlying sepsis, sir.
Yes. So you are now with these two things in my in the background. Would you like to rephrase your diagnosis? Only a pancreatic fistula or pancreatic fistula with
sepsis, sir.
Sepsis. And how do you explain vomiting on 8th post-op day? 8th post-op day, most of the Whipple's patients start having their oral feeds, but he is having vomiting even on 8th day.
Sir, patient may have the dyselectrolemia. So
anything else? Anything else which is common after Whipple's? It's a described entity following Whipple's.
Sorry, sir.
There is a distinct entity when patient may have distension, persistent vomiting after Whipple's, even on 7th, 8th, 10th day.
Especially after classic Whipple's procedure. where you preserve the pylorus of the stomach. You meant that, sir?
Have you heard
The
of
anastomoscopic
delayed? No. Have you heard of delayed gastric emptying?
Yes.
That is one of the consequence of a likely PJ leak. Okay. So because you are given lot of findings, so keeping in that mind these findings, you should try to think of what might be the situation going on in a particular patient. Because most of the time you don't give such a big scenario, but once you are given, you should interpret each of these complaints. Okay, so there is a possibility of even delayed gastric emptying in this patient. Okay, so he's vomiting. A patient having sepsis may vomit, but patient vomiting on the 8th day is not usual for a Whipple's patient. Okay.
Oh. Now, how do you like to confirm that what you are thinking that it is probably a pancreatic fistula? How do you like to confirm that?
Sir, I will do the biochemical test. I will measure the amylase level of the drain and the serum amylase level on the same day with the same lab. If there is if the drain fluid amylase level is 3 times more than the serum amylase level from the same lab, then it is a diagnostic of pancreatic fistula.
So how do you define pancreatic fistula? Define pancreatic fistula.
Sir, pancreatic fistula defined as any miserable amount of fluid coming through a operatively placed drain, usually after 48 hours of surgery, in which the serum amylase level after
not 48 on the third.
You see, you are giving a international pancreatic study group definition, so stick to that definition. This is a definition you are giving is the international study group of pancreas. Okay, they don't mention 48 hours. Yes. 72 hours.
Third post-op.
Yes, on the third post-op day, any measurable drain output having drain amylase 3 times the serum amylase.
More than the serum amylase.
Yeah. So you should put this is a standard definition coming from international study group.
Okay, so 3 times the upper normal serum value for that particular laboratory. Okay.
Yeah. Yes.
So laboratory, the upper level may vary. Okay.
Yes.
Or now, do you like to do any imaging in these patients? In case you like to do
yes,
it.
Sir, I will. Yes, I want to do
what?
CT scan of the abdomen to look for the. Hello.
Why?
Hello.
Yeah, I can hear you.
Sir, I will do this. Yes, I will do CT scan to look for any collection, or sir, look for the quantity and the site of the collection, and also we can see the position of the drain, whether it is correctly placed or not, and sir, we can also.
Do you think that in this patient drain is functioning well? Even in the ultrasound report?
Yes, sir.
Yes. If you have significant collection and drain is draining 100 ml, you think drain is all right from your part? I don't think. Patient has ultrasound showing significant collection. CT might show much more. And drain is 100. So this is a situation that drain is not functioning well, and more so, patient has got a left saprophrenic collection. Why do you place the drain after PD?
Yes, sir. Hello.
Why do you place the drain?
Sir, where do you place drain any
Where?
What is the location of the drain?
Hello.
Yeah. Where do you place the drain? Where do you keep the drain?
Sir,
a very standard place you place the drain. What is that pouch called as?
Morrison's.
Yes.
Yeah.
So there is a right subhepatic space you put the drain. Yes, and even then on the right side there is a significant collection. On the subhepatic side there is good amount of collection. So you should assume that the drain is draining 100 ml, but maybe that drain is partially functioning.
Not sufficient. Yes.
So what's the role of imaging, as you said? Can you summarize once again?
Sir, we can look for the site of the collection and amount of the collection, and sir, if we see the whether drain is correctly placed or not, and if intervention required, we can
No. Before intervention. If you're given the oral contrast, do you look for something else? You have given the patient oral contrast during CT. Can it give some more clue for any other thing?
Leakage.
Where? From where?
Leakage from the anastomosis.
Which anastomosis?
There is a leakage.
Which anastomosis is more likely to be seen with a oral contrast being given? Although that leak is not very usual. You don't have more commonly. Yes, GJ leak.
Gastrogestion.
Yeah. It's not very common to have GJ leak, but sometimes the GJ leak may happen. So in the oral contrast, you also should look for any contrast leakage.
Yes.
Anything else that you can pick up? Other sinister things that can happen in such cases?
Sir, yeah, we can look for the pseudoaneurysm.
Yeah, sometimes pseudoaneurysm of the splenic artery can occur in such scenarios that can be picked up. So does it have a role in the diagnosis proper, that it is a pancreatic fistula, the imaging I mean?
It's a CT scan.
Yeah.
Sir, CT scan, sir, will not give the detailed structure about the pancreatic ductal anatomy. So we will have to go for the MRCP.
MRCP? Don't jump to something which is not done. Have you ever done MRCP for a patient having post-op PJ leak? It's never done.
No, sir, CT.
Half of the bile duct is gone. Half of the bile duct is gone. Main PD is gone. Don't say something which is not done at all. Dr. Bhacha asked you a specific question. Whether in CT scan you make out, yes, there is a PJ leak. Can CT scan person tell you, yes, there is a PJ leak? Can he demonstrate that? Very unlikely. How can he say? Because if you are doing the contrast is not going to the PJ site.
Yes.
So your answer to me is unlikely that I can pick up.
Yes. So imaging is not much useful in the diagnosis proper, in establishing that diagnosis. Diagnosis will be established by noting that the amylase level in the drain fluid is 3 times the normal serum value for the laboratory. Okay, you can also use, as you said, the CT scan to drain whatever collection is not draining properly in those in the subhepatic space, subphrenic space, left subphrenic space. You can put in image guided pigtails so that those loculated fluid gets drained out. All right.
Yes.
Okay. Yes. Now,
Anish, with this scenario, why do you place this pancreatic fistula grade A, B, C?
Sir, with this scenario, sir, I will want to put this patient in the grade C, sir.
Why grade C? No.
Sir,
I'll put the patient
as the general condition of the patient.
Yes, even in grade B, patient will be moderately ill. Especially if patient is ill. Okay, she has tachycardia of 100. So grade C is specialist, try to understand. Grade C, the specification is patient is critically ill. Okay, patient has organ failure. You don't have any scenario that patient has got organ failure. So ideally, you should put this in grade B, not grade A. That I want to ask you. Grade A is not the scenario. This is grade B, and if you want to say grade C, you have to justify. Why do you say this patient is grade C? What are the criteria for grade C?
Sir, patient is ill, and sir, patient having the sepsis.
No, patient should be critically ill. Patient should be critically ill. What else? Grade C?
Sir, patient is sepsis. Sir, sepsis is in grade C, not in.
Yes. What else? What else in grade C?
Multiple organ dysfunction, sir.
Yes. It should be the tune of organ failure. And with regard to intervention?
Doc.
With regard to intervention? Huh?
Yes, sir. Required urgent intervention, sir.
What intervention? If you just if you are just doing a pigtail drainage, that is not the situation of grade C. Minor intervention.
Some surgical intervention.
Yeah.
Yes.
Minor intervention is grade B. But if the patient requires major intervention, then it becomes grade C. So try to understand. These are the very important part of pancreatic fistula discussion, where you have a specification of grade A. What grade A is particularly called as? Grade A has got a different name.
Biochemical leak, sir.
Biochemical leak. How does it understand? What do you mean by that?
Sir,
You say there is a biochemical leak. That means?
Sir, there is no evident collection in the radiological. There is no any evident collection.
There may be minimal collection, but patient is not having any symptoms.
Symptoms.
And what is the clinical importance of that?
Sir, it is treated by, sir, it resolves spontaneously by conservative treatment.
It will invariably resolve with spontaneous treatment.
Okay, now, can you understand?
Yeah. Can you classify, how do you classify pancreatic leak?
Sir, pancreatic fistula may be classified as external or internal. Okay. Sir, in the internal, it may be the pancreatico-peritoneal or pancreatico-pleural, sir. And in the external classification, it is the pancreatico-cutaneous.
And thoracopancreatic fistulas can be further subdivided into?
Pleural, thoracopancreatic, sir, pleural and mediastinal.
Mediastinal, pleural, bronchial.
Bronchial and thigh.
Yeah, and it can also go into the pericardium also, really. All right.
Yes.
What is the importance? Like, for example, if it is a pancreatic, that is, the fluid is collecting in the peritoneal cavity and fluid is collecting in some patients, fluid is collecting in the mediastinal cavity. What is the basic reason behind this? In which cases will there be pancreatic ascites, that is pancreatico-peritoneal fistula, or in which cases there will be a thoracopancreatic leak?
Sir, if there is an anterior leakage, then it will pancreatico-peritoneal, and if the posterior.
Very good.
Yes, sir. And if posterior, then it's pancreatico.
Mediastinal. Okay, or pancreatico-thoracic. Yes. And etiologically, can you classify the pancreatic fistula also? This is the broad classification. And then etiologically, how do you classify it? Etiologically.
Sir, etiologically, iatrogenic or non-iatrogenic, sir?
Very good. Iatrogenic or non-iatrogenic?
Non-iatrogenic. Sir, in the iatrogenic, sir, it is any intervention, any surgical procedure, sir, or ERCP, sir, or any instrumentation, sir. And non-iatrogenic, sir, it is a trauma or.
Anish, any names of operations? One is direct operation, the pancreas can become pancreatic fistula. Apart from this, some other operations, which are not exactly pancreatic operations, can cause subpancreatic fistula, like?
Sir,
it was not a pancreatic operation, but patient has pancreatic fistula.
Something to do towards the tail of the pancreas?
So splenectomy?
Yes. Can pancreatic fistula happen following splenectomy? Can it happen?
Yes, sir.
How? What may go wrong that patient has developed pancreatic fistula following splenectomy? What part of pancreas? Yes.
You are doing an emergency splenectomy. Scenario is an emergency splenectomy. Patient is breathing, not hemodynamically stable. You are very fast. What can happen? Go wrong.
Injury to? Injury to pancreatic tail. Pancreatic tail is lying in the splenic hilum. Understand?
Yes.
So if you injure pancreatic tail and any other operation which can cause some problem and can lead to pancreatic fistula. Gastrectomy.
Yeah.
Gastrectomy. Okay. While you doing gastrectomy, you can injure the pancreas and patient may pancreatic fistula. Okay. So you should keep in mind, you see post-operative. So direct operation is one, and other operations you may have pancreatic fistula. Fine. Okay.
And you shouldn't forget about, say, pseudocyst of the pancreas, a complication, say, of
Cystogas. Yes.
of chronic pancreatitis, where sometimes you need
Yes.
to put in a percutaneous drain, and if
Yes.
say, there is an obstruction in the main pancreatic duct proximally, so that particular pectoral catheter will keep on draining. So that is also a type of pancreatic fistula. That is continuous drainage through a percutaneously placed drain, especially for draining following drainage of a pseudocyst. Okay. What are the
Yes.
non-iatrogenic causes you said? Non-iatrogenic is also another subgroup.
Sir, pancreatic trauma,
Yeah,
and
very good.
sir, chronic
Pancreatic trauma or an abdominal trauma you mean?
abdominal trauma, sir.
Yeah, blunt abdominal trauma.
Yes,
Where
blunt
does
abdomen. Yes.
where does the pancreatic duct get physiology in such cases?
Hello, yes, sir.
Steering wheel
Where
injury. One cause, important cause is steering wheel injury when there is impact. What is the common site of pancreatic injury? If you have got a history that patient was driving a car and then he has got a steering wheel injury. What is the common site of pancreatic
Sir,
injury?
head
Head.
of the pen.
Are you
head?
sure?
Head and body.
Head and
Head and
what?
body of the.
You are out of the main site.
Think about the mechanism. Say the body gets.
You are leaving behind the part which is commonly injured. We are going to head and body. It's a neck. Because that is the area where the pancreas get impact
It
against the
is
vertebral body.
yeah.
Understand? If you have steering wheel injury, you have the impact on the anterior abdominal wall, and pancreas gets sandwiched between the anterior abdominal wall and the vertebral body. And commonly, that is the area of the neck which may get transected. There will be spontaneous transection of the pancreatic neck, not the head. He may have injury in the head. I agree. Any blunt trauma can cause head injury, can cause body injury, but the common site in a particular this steering wheel type of injury is commonly the neck of the pancreas.
Can pancreatic fistula occur following just a severe acute pancreatitis? Can it occur?
Pancreatic fistula after severe.
Acute pancreatitis.
What happens
No.
in severe acute pancreatitis? What happens to the pancreas?
So this is a parenchymal damage of the pancreas
Yes.
by the
So what
toxins.
happens? The parenchyma can slough.
Yeah.
Understand? In severe acute pancreatitis, the parenchyma sloughs up. That is the necrotic material. So in that process, even the duct may be get disrupted.
And
So
the patient can land up with a pancreatic ascites.
Yes.
Just a passing question, and just like in case of blunt abdominal trauma, the neck is the common site. What is the common site for this sloughing out of the pancreas in case of acute pancreatitis, which leads to pancreatic fistula? There is also a common site. So it usually occurs at what is called the genu of the pancreatic duct, where the pancreatic duct, if you follow the pancreatic duct, you'll find it suddenly bends down. It comes from the tail body, and then towards the head, it suddenly bends towards the when it goes towards the duodenum. That point where it bends is called the genu of the main pancreatic. That is the common site for of sloughing off of the pancreatic duct following acute pancreatitis.
Okay, Anish, if I come to the pancreatic surgery, I have done a pancreaduodenectomy, I have done a distal pancreatectomy, I have done a median pancreatectomy, or I have done a simple enucleation. Out of these four scenarios, where do you expect highest incidence of post-operative pancreatic fistula? Highest.
So distal.
Sure. Very small operation is enucleation, but highest rate of pancreatic fistula. If their enucleation is within 3 millimeters of the pancreatic duct, is as high as 70%. Understand? Distal pancreatic has more incidence than the PD. Median pancreatic has more incidence than the PD, to the tune of about 40%. But highest incidence is following enucleation. Keep in mind that enucleation is a small operation, but the most important complaint following enucleation is the pancreatic fistula. Okay, so these are the incidence of fistula following pancreatic surgery.
So that should be another, iatrogenic cause of pancreatic fistula formation.
Fistula.
Okay. Now
Yes.
that you have diagnosed that the patient is having pancreatic
Few more things, Dr. How can you predict?
Yes.
During operation, who are the patients who are likely to have more chance of having pancreatic fistula in the post-op period? Any predictors?
Sir, preoperatively also.
Yes.
Sir,
there are some.
Sir, preoperative factors, sir, like some elderly patients. And sir, elderly patients, sir.
Elderly patients. What else?
Elderly patients.
If you talk about sex predisposition, male, female.
Sir, male has more chance of.
Male has more chance. Yes, agreed. Then.
And sir, general condition of the patient.
Like what general condition? Malnourished. If patient is overnourished.
Yes, sir.
Yes, malnourished will include both malnutrition and obesity. Patient. What else? What pre-op factors are more?
And sir,
anemia,
sir.
If you are operating for a chronic pancreatitis versus other conditions, what do you think?
So in the if we operate for the malignancy, then there is a more chance of the pancreatic fistula formation.
It is said that the malignancy and chronic pancreatitis chance is less than you are operating for a duodenal tumor or a islet cell tumor. Understand?
Can you give an explanation for this?
Yeah.
What is the explanation?
Sir, if sir, in the case of the other conditions, apart from the chronic
in this condition, patient has a malignancy or chronic pancreatitis, what happens to the pancreas? Is there a
pancreas?
Yeah.
So pancreas is due to recurrent infection and the fibrosis. Pancreas
not exactly infection. Not exactly infection. Chronic pancreatitis, the pathology is not infection. What is the pathology?
Inflammation.
Inflammation.
And obstruction.
Obstruction.
There is obstruction in the PD, and because of obstruction and inflammation, there is fibrosis. The gland become more firmer.
Firm, yes, sir.
The duct become wider.
More, yes.
Okay, so if you do anastomosis in this situation, the chance is little less than you are operating for a duodenal tumor. PD is not affected. You are operating for a islet cell tumor. Okay, so there are the situations where the PD is not dilated, the duct gland is not firm, gland is soft, so there is more chance. Okay, in any intraoperative factors, anything to do with the duct diameter? Any prediction depending on the duct diameter? What is that?
Sir, if there is a duct diameter is more, then there is a more chance of.
What more? There is a specific. There is a scoring system.
More.
There is a scoring system which takes in the duct diameter and predict and give some score based on the duct diameter.
Sir, more than if there is.
You heard of any fistula scoring system? Fistula risk scoring system? You have not heard. You try to read. There is a system called fistula risk scoring system, which takes into account the condition of the gland. Condition of the gland, whether it is firm or soft. If it is firm, the grade is 0, score is 0. If it is soft, it is 1. Okay. Then there are some other markers like pancreatic duct diameter, then intraoperative blood loss.
Texture.
Okay. Intraoperative blood loss. And another important thing is why you are operating. If you are operating for adenocarcinoma or chronic pancreatitis, the score is 0. If you are operating for other reason, as I say, duodenal or either islet cell tumor, the score is 1. Okay. Oh, sorry. The first point was 0 and 2. Gland is firm, 0. Gland is soft, score is 2. Okay. And then if you are operating for adenocarcinoma or chronic pancreatitis, the score is 0. And if you are operating for other conditions, score is 1. Next is the pancreatic duct diameter. If it is more than 5 millimeter, score is 0. 4 millimeter, score is 1. 3 millimeter, score is 2. And then 1 millimeter, score is 1. Okay, so you have a score from 0 to 4. And if you take the intraoperative blood loss, less than 4 ml blood loss, 0. 400 to 700 is 1. 700 to 1 liter, 2. More than 1 liter, 3. So there is a total score of 10. So we can predict, depending on this scoring system, the highest score will be 10. Lowest will be 0. If it is 0, the risk is negligible. If it is 1 to 3, it is low risk, 6%. If it is 4 to 6, it is moderate risk. 7 to 10 is very high risk. So you should know this scoring system, because pancreatic fistula discussion, the examiner will go on to this part of the discussion also. Okay, so this is fistula rescoring system.
So in this context, may I ask you, say, suppose you are getting a say pancreatic head malignancy and another patient of periampullary carcinoma, where will be these chances more of the pancreatic fistula development? Carcinoma
sir,
head
out of pancreatic head carcinoma and pancreatic
and periampullary.
periampullary carcinoma. Sir, in the
just in the context of what Professor Shah just now told you.
Sir,
Where do you
periampullary carcinoma?
Chances will be more.
Yes.
That's what you. Yeah. Why?
Sir, because sir, pancreas will be more softer and there is a
and the duct will not be too much dilated. It's because the detection of these cases are very early as compared to pancreatic head malignancy, where the process is a very slow and gradually progressive jaundice occurs, and there is a time for the duct to dilate properly. The glands will become firmer in the process, so there the chances are less in case of head of the pancreas carcinoma proper as compared to periampullary sphere. Okay. So how can you? So keeping again these things in mind, what are the things that you can do peroperatively when you are doing a pancreatic gynectomy? Can you do anything which can prevent development of pancreatic fistula in those high risk cases? Understood my question?
Yes, sir.
Is there any
Sir,
way of
does your operative technique have a bearing on outcome of pancreatic fistula?
No, sir. Operative technique do not have any major significance.
No, there are some factors you should take care.
Yes, some factors are there, sir.
Like,
sir,
sir, you should ensure that the pancreatic stump is vascular, is not ischemic.
Yes.
Okay,
sir,
number one.
Yes.
Okay, and you see that the pancreas is soft, you have more chance of having fistula. So operative part is also important while you are doing. Now come to the technique. Is there a correlation between a pancreatic-jejunal anastomosis or pancreatogastric anastomosis in the outcome of pancreatic fistula? What's your opinion?
No, sir.
A PG student cannot say just one word. No.
Sir. Yes, sorry,
PG student has to have some points to say in favor of PG and PG.
Yes.
See, there are a lot of things in between these two. Dr. Bhattacharya is in favor of PG.
So there have been some studies which said
various
that,
studies. Yes.
Few studies which have claimed that pancreaticogastroscopy is a better option than pancreaticojejunostomy.
But that's what I'm saying. Just don't say, end up with saying no.
Yes.
Leave a discussion.
But overall, it has not been, over a number of randomized controlled trials did not prove that specifically that one is better than the other.
Yeah.
Neither is use of stent or no use of stent.
Yes.
Uh,
So
other things.
what I can say is there are some publications
Some
claiming
studies.
that
Yes, sir.
following PG, the risk of pancreatic fistula is less. But there are other studies in publication which shows that yes, it's comparable. So PG is not superior to PJ.
So, but
Okay.
only thing that can be of help is, as sir said, that you have to be
Such
very gentle in your surgery.
gentle.
Uh,
Yes.
yes, you have to ensure that do not do too much of dissection around the pancreatic stump that can devascularize the
Yes.
pancreatic stump. Uh,
Yes.
uh,
Less use of
uh,
diaphragm.
yeah, when you are tying the knot, don't tie it too tightly. So if you are rough about during tightening, during tightening the knot, it can cut through the tissue. That can lead to development of small leaks. And so basic adherence to the basic principles of pancreatic jejunostomy is the key for prevention of pancreatic fistula. Even octreotide or no octreotide, that has been studied. It has not been proved conclusively that use of octreotide can reduce the chances of pancreatic fistula.
Anish,
Now,
Anish, the gland is soft, duct is very small, difficult to identify. How are you going to tackle the situation during surgery? Very soft gland, very difficult to localize the gland, very small duct. How are you going to address during surgery? Any alternative? We discussed about PG and PJ.
any
But
other way?
in this situation, like this, very small duct sometimes cannot be localized what the duct is, and very soft gland, what can be the alternative for you during surgery? You should know that. That is one of the important pancreatic management, stump management. That is known as invagination.
So instead of duct to
Invagination
mucosa and
technique or dunking.
instead of duct to mucosa anastomosis, you just do a dunking.
Okay. So you insert this pancreas either to the stomach or into the jejunum. There is a different technique which goes by the name of dunking. Okay. So some people claim that the original publication that came from dunking group, they are saying they have zero pancreatic fistula. But subsequent people have studied that they are not saying it's zero. There is some incidence of pancreatic fistula following that also. Okay, but you should know this technique. Okay? This is described as invagination or dunking technique.
Now, how would you like to manage this case?
Yeah.
Sir,
This is the
firstly,
patient.
I will go for.
This is the patient in front of you, and you are trying to manage the patient. Anything else you like to have? Any other information in this patient? Or you are happy with this? I'm not happy with this. This is a particular scenario given pointing towards a pancreatic fistula. But on the 8th post-op day, are you happy or you like to ask some more questions and make some more assessment? Patient is sick. He is having fever. I don't like to explain everything by pancreatic fistula. What might go wrong on 8th post-op day? Don't forget about chest complications. Don't forget about a deep vein thrombosis. Okay. Don't forget about other organ failures. So your answer should be, sir, in addition to this, I like to take a more detailed history. I like to examine the lower limbs. I like to examine the abdomen in details. I like to examine the chest. Okay. So you have to make a comprehensive assessment. Don't be focused only on the pancreatic fistula. On 8th post-op day, patient is ill. So I am not happy with only pancreatic fistula. I have to do a global assessment for the patient. This can be a GJ leak. This can be a HJ leak. Okay, so you should keep your mind open and do a proper assessment of the patient, taking a detailed history, examination, and then if you feel that patient has got a suspicion of deep vein thrombosis, what you will ask for? Patient has a possibility of deep vein thrombosis, there is swelling in the calf, there is tenderness. What you should ask for?
So, invest the venous Doppler.
Venous Doppler, yes, and doing a D-dimer. You should do a D-dimer study.
Yes.
Okay, fine. Keep in this. This is the situation. How do you go?
Sir, after proper assessment, as you said, sir, ruling out the DVT and the chest infection, I will do some. I will go for the resuscitation of the patients before going to any intervention. After proper resuscitation, I will
No,
optimize the patient.
what do you
Sir,
mean by
keeping patient
resuscitate?
Hello.
What do you mean by resuscitate? Don't be give a broad answer. What you
Yes.
do to resuscitate this patient?
Sir, I will keep the patient NPM. I will start the IV fluid. I will start, sir, as patient is having fever, so antipyretic. I will start antibiotics, sir, and then, sir, I will go for the sir, definitive treatment, sir.
Huh? I
Sir,
didn't
then
get
I
you.
will go for. Hello. Hello.
Last point you said.
Sir, after the after these things, like, sir, I will keep the patient NPM, start antibiotic, antipyretic, antiemetic, sir.
So
And,
you answer like this, that these patients are usually dehydrated. So I want to ensure that the patient's hydration has been optimized. These patients
Yes.
are usually malnourished. Okay,
Yes.
because they undergo, go into the catabolic state. So I will have
Yes.
to ensure that the patient's nutritional status is properly optimized. If required, most of these patients require total parenteral nutrition. Okay.
Yes.
I'll keep the patient nil orally, of course, and over and above that, I would like to take certain measures which will reduce. These patients are usually in a metabolic. What happens? Metabolic what?
Metabolic acidosis.
Yes, metabolic. Why? Why?
So there is a dehydration. So dehydration may lead to the
No, because the pancreatic
tachypnea, sir.
Pancreatic juice is very high, has a very high content of bicarbonate. So these are lost. So
Yes.
that leads to the metabolic acidosis. That needs correction also. So hydration, fluid dehydration, nutrition, the correction of your metabolic acidosis, and IV antibiotics. I like to reduce the output by using certain drugs like.
Sir, octreotide.
Yes, octreotide. With the use of octreotide, I would like to reduce the output. Next, what patient is having loculated collections, which may be the cause for this features of sepsis. The drain, it is not a controlled fistula, so some amount is collecting here and there. So I will need to.
How do you tackle this collection?
Sir, USG guided pictorial drainage, sir.
Yes, I will like to drain out whatever collection is there by putting in image guided pigtail drain. Okay.
Yes.
Then
Anish, you wanted to say during metabolic acidosis, there's tachypnea is one reason for acidosis. What is the alteration in tachypnea?
What happens?
Washout, sir.
What happens?
CO2 washout, sir.
So
that leads to?
That is respiratory alkalosis.
Alkalosis, yes, yes.
It cannot be acidosis if the patient is tachypnea.
Yes.
Don't say something. It's a PG exam. If it's
Yes.
something wrong, the examiner will be after that.
Yes.
Yeah. And then what are the other problems with these patients? You have told about IV antibiotics. Okay. What are the other problems? These pancreatic fistula patients can have a bad, skin related problems. The drainage site may get gradually, the skin around the drain will get inflamed, it will get exfoliated. So you need to protect the skin also, otherwise everything will be eaten up basically. Okay, so you have to protect the skin. Then what else can you do? Now you have done an imaging and you find that the drain has gone, the tip of the drain is almost sitting near the anastomosis. That is one of the reasons where the fistula is not unlikely to close. If the drain is very close to the anastomotic site, the fistula will and it will keep on draining. So
Yes.
what needs to be done in such cases?
So replacement of the drain, we will pull out
Repo
drain little bit.
yeah, repositioning, not replacement, but you have to withdraw the drain a bit so that it is away
Yes.
from the site of the anastomosis.
Fish. Yes.
Then again, if required, you might have to exchange that drain at a later period of time, of course, by some literature claims that if you exchange the normal drain that we put in, which is very inert, with type of a red rubber drain, okay,
Yes.
and then fix it, that red rubber drain will incite fibrosis around the tract, and that can lead to rapid closure of the fistula. So replacement, repositioning, and later on, if required, replacement of the drain. And with this, how many patients how much of the patient population of pancreatic fistula would you expect to heal spontaneously with these measures?
With conservative management.
Yeah, with these measures only. Post Whipple's pancreatic fistula.
You should answer this based on grade. Grade A, grade B, grade C. Can you just answer like that?
Sir, in grade A patient resolves spontaneously, sir.
Yes, 100% is likely to have spontaneous closure.
Yes,
grade B and grade C.
Sir, grade B patients are, most of the patients are all,
yes.
Most of the patients resolved by 3 weeks, sir.
Yeah, almost 95%.
95%.
But yeah, grade C patient will require some major intervention.
Yes.
Okay. It's very unlikely that grade C patient will be getting healed by just your conservative measures. It's very unlikely. Some of these patient is further deteriorating. You put a big tail, but sepsis is not getting controlled. More and more drain is coming up. More intra-abdominal collection. Patient is getting more critically ill. What should be your steps then? This patient is getting further down on the downline of 10th, 12th day.
Sir, I will go for the sir, I will go for the surgical exploration of the
what surgery. Now you opened up. What do you assess?
Sir, I will assess first. I will assess the site of the leak, sir.
PJ leak. What do you assess?
Sir,
there is a major PJ leak. It's not a one point which is leaking. There is a major PJ disruption. Major. What should be your tip?
Sir, total pancreatic.
Anything else short of that? Total pancreatectomy has very high morbidity and mortality. Anything else short of total pancreatectomy?
Pancreaticogastroscopy.
Yes. So you can revise this to pancreaticogastrostomy, or in desperate situation, you can consider for doing a total pancreatectomy.
Yes. I think we have touched upon most of the
this is the
most of the points we have touched upon.
Anish, what do you mean by duct to mucous anastomosis? What is that exact technique? What do you do when you say we are doing a duct to mucosa technique of anastomosis? What is that anastomosis? How do you do that?
Sir, imagination.
Hey, imagination is not to duct.
So
that is not.
So that is.
Have you seen a PD?
No. Sir.
Have you seen a Whipple's operation? You have not seen. Okay. So the technique basically is, you see, there are different techniques of doing pancreatojejunal anastomosis. One is you can go by 4 layers. So what you do is you apply a pancreatic capsule to the serosa of the seromuscular coat of the jejunum posterior. Then you incise the jejunum to the same extent as the raw surface of the pancreas. Okay. And then keep on putting sutures. And while coming to the pancreatic duct, ensure that you can take a bite from the duct mucosa to the jejunal full thickness bite. Okay. That is the second layer. Come back on the third layer, anterior pancreatic parenchyma, the duct mucosa, and the anterior cut in the jejunum. And then apply another layer, taking the pancreatic capsule and the seromuscular of the jejunum anteriorly. This is a standard 4-layer technique. But if you talk of a specific duct to mucosa, you make a small rent in the jejunum, matching the pancreatic duct, and take the pre-tight bites from the pancreatic duct. Depending on the duct diameter, it can be 4 or can be 6. Okay, so apply a pancreatic capsule to the seromuscular coat posteriorly, and then make a small rent in the jejunum, matching the pancreatic duct.
Fish
And
mouth.
take bites with fine PDS sutures, maybe 40 PDS, taking bites from the duct mucosa, pancreatic parenchyma, and the all coat of the jejunum, taking the mucosa of the jejunum. And then apply a anterior suture, taking the pancreatic capsule and the seromuscular coat. This is the specifically duct to mucosa technique of pancreatojejunal anastomosis. Okay.
Now, sir has told you about 2 techniques. All right.
Yes.
Understood. So both are duct to mucosa. Both anastomosis pancreatic duct with the jejunal mucosa. Now, where do you think which do you think is better and why? Understood.
Yes.
So you don't have much an experience with pancreatic. Just think about the scenario. Which is better in this case? Where one is a small fish mouth like opening on the jejunal side on the serosa, and then anastomosis between the duct and the jejunal rent.
Yes.
And other is a entire width of the pancreas is being anastomosed with a rent in the jejunum. Wider rent in on which is better?
So duct to mucosa are small.
That will be better.
Will be better, sir.
Yes. You see, there are some small ducts.
Yeah.
There are small ducts on the surface of the pancreatic parenchyma.
So
people who are proponent of the duct to mucosa, they say that the small duct is obliterated. But people who are doing the full anastomosis, they are saying that if you do this full length anastomosis, the small ducts also drain. But you see, outcome of fistula is almost comparable.
Yes.
Anything else? No, nothing in the chat box. Glue. Yes.
Yes. Suppose I just asked one question. Suppose you said I'll do imaging for detecting pseudoaneurysm. In case you detect one, what should be the treatment from your side?
Sir,
you could demonstrate a pseudoaneurysm. Patient has not bled yet.
Yes.
What should be your step?
Grade 1 with pseudoaneurysm, sir.
Yes, you have diagnosed a pseudoaneurysm on your routine triphasic CT, but patient has not bled yet.
These patients can suddenly bleed, and can the bleed may be the hemorrhage may be fatal.
How can you tackle? What is the recent trend in management of this sort of pseudoaneurysm? Even if he is bleeding, it will be interventional radiology.
So it will embolization.
Angioembolization. Okay. If I ask you last question, what are the consequences of this pancreatojejunal anastomosis leakage? What can happen to this patient? Consequence of PJ leak.
Sir, sir. So patient.
One you said is if it is grade A, no consequence. Patient may have some delayed recovery, but otherwise there is no specific symptoms because of this. But if it is a severe grade of pancreatic fistula, patient may have number one, delayed gastric emptying. Patient may have collection in the peritoneal cavity. Patient may have sepsis, fever. Okay. Patient has delayed recovery. Patient may have organ failures. Patient may have multi-organ failure. and the last
ultimately death.
consequence may be death.
Yes.
So these are the consequences of post-operative pancreatic fistula. And most important part in management of the pancreatic fistula is you have to monitor the patient.
Sepsis.
Monitor is very important. To even in grade A fistula, you should monitor whether this patient is passing on to the grade B. Because this patient who was not having symptoms, now having fever, now having delayed gastric emptying, is having vomiting. So you should always monitor the patient to diagnose whether the patient is proceeding to the next phase of complications. Okay, so you should be knowing the consequences. So we have almost discussed 1 hour for pancreatic fistula. It's too long. You'll not be. You'll having 10 minutes time in the exam.
5 more minutes. Can we ask 1 or 2 more questions to cover up that 5 more minutes that is left?
Yeah.
Oh, 4 minutes, 3 minutes, I think.
So you'll not be asked so much of question, but you should at least be knowing the definition of pancreatic fistula. You should be knowing the risk factors for developing pancreatic fistula. You should be knowing the fistula risk scoring system. And then you'll be knowing the grades of fistula, grade A, B, C. What are the clinical markers for grade A, B, C? And then investigations and the management of each of these. Okay, so these are the basic things. And then some discussion on relation between putting a stent and pancreatic fistula, relation between octreotide and pancreatic fistula. So there are some discussions on this also. How can stent be the factor for pancreatic fistula? People using stent claim that there's less chance of fistula, but subsequently it's proved that stent does not reduce pancreatic fistula. Even with octreotide, patients started having octreotide, patients started claiming that the incidence fistula is less. But subsequent study has proved that is not interfering. But a lot of a lot of people are practicing giving this patient octreotide in the perioperative period.
The sir was asking about this delayed gastric emptying. We had stressed upon this number of times. Which type of pancreatodectomy is this delayed gastric emptying more commonly seen? There are two basic types of pancreatodectomy. One is the pylorus preserving, and another is the classic, Whipple's procedure, where you do a distal gastrectomy. Where is this delayed gastric emptying?
So distal. In case of distal gastrectomy.
No.
Distal gastrectomy.
The pylorus preserving having more incidence of delayed gastric emptying.
Yes. Okay. So some people do a little bit of dilatation of their pylorus also.
Yeah.
Stretches the pylorus a bit to avoid this complication. And in case it develops, what do you do? What do you have to do actually?
Sir, if it develops, frequent meals, sir.
Treatment is
less carb, less. What? Sir, small frequent meals, sir.
No, delayed gastric emptying. Patient will keep on vomiting, so that's why you have to put in a rice tube. So,
can you name any drug which can help in this situation? We used to give some drugs at the end of maybe 10-12 days, which can increase the GI peristalsis.
Sir,
erythromycin and metoclopramide, this increases the gastric.
Erythromycin is used long for this. You should not use at the beginning. You wait and see whether this is resolving spontaneous or not. Correct the electrolyte imbalance if it is there. Okay.
The only thing is to keep the rice tube till the stomach keeps on draining a lot of fluid. Over a period of time, when the gastric tonicity returns, you will find that the gastric output is gradually reducing, and then you can start allowing small feeds and see whether the patient again starts vomiting. Usually it resolves over a period of time after just simply keeping the rice tube in place for some period of time.
Okay, Dr. Varchaj, thank you.
Thank you very much. Thank you very much.
Thank you.
Thank you, sir.
We had very nice discussion. Thank you.
Thank you.
Thank you.
Thank you, Anish.
Thank you, sir.